It's 12 o'clock, so in the interest of time, we'll go ahead and get started. Today we have Dr. Carson Cook, who is going to present to us on literature surrounding timing of oral anticoagulation initiation in patients with AFib after a cardioembolic stroke. So she's done a lot of legwork researching background information and tying in some of the most recent studies that are helping to answer a pretty difficult clinical question. So with that, I will give you the floor.
Thank you all so much for being here. I'm really excited to get to share some interesting updates related to resuming anticoagulation in patients after a stroke. Of note, I have no financial or other disclosures that would impact this presentation. So as far as objectives, some things that I hope you can take away at the end of this presentation include being able to explain why it's important to resume anticoagulation after an ischemic stroke, as well as be able to classify a stroke based on severity, and be able to compare and contrast some primary literature related to timing of oral anticoagulation after an ischemic stroke. And finally, be able to apply all of that knowledge to a patient case. So to start out, here's our first knowledge assessment. So what is the time period after acute ischemic stroke during which the risk of recurrent stroke is the highest? Is it A, within 2 weeks, B, within the first 3 weeks, C, within the first 4 weeks, or D, within the first 5 weeks? C, exactly. So within the first 4 weeks poses the highest risk for recurrent strokes. And as we'll see later in the presentation, this 4-week mark is likely what drove some of the trials in the literature and kind of contributed to some of their certain timings of endpoints. So as far as risks, obviously we know that strokes are very common. The 2023 stroke statistics update from the AHA showed that 87% of strokes are ischemic strokes, which is the leading cause of serious long-term disability. And every 40 seconds, someone in the US has a stroke. So obviously very prevalent, especially among our patient population. And as you can see here, based off the list, there are both modifiable and non-modifiable factors associated with strokes. But for the purpose of this presentation, we'll kind of be honing in and focusing on atrial fibrillation as it's associated with a high risk of stroke recurrence. And to help prevent strokes in AFib patients, we want to make sure that we're treating it appropriately. So primarily that's looking at targeting the rate, the rhythm, and anticoagulation if medically necessary. And so this is primarily done using medical management strategies. However, we know that there are non-medical management strategies for AFib treatment as well. But again, we'll be focusing on this anticoagulation piece of AFib treatment. And to better understand kind of this underlying need for anticoagulation among AFib patients, we'll look at how it can actually cause a stroke based off of the pathophys. So ultimately, this goes back to Virchow's triad. And so we have this blood stasis, this endothelial damage, and hypercoagulability. And so all three of these things, both independently and collectively, kind of work to form a thrombus, which ultimately can lead to a thromboembolism, leading to an ischemic event. And so one way that we can target this triad is by utilizing anticoagulation. But again, we know based off of how we treat AFib that not all patients warrant anticoagulation. So how do we determine who gets anticoagulated? So as far as figuring out who would benefit from this, AHA guidelines use the CHADS-FAST score, which is seen here on the left. And just as a refresher, so when you're looking at scoring of CHADS-FAST, it's based off of the non-sex score. So males greater than or equal to 2, females greater than or equal to 3. And that means that a patient is at high risk of developing a thromboembolism and anticoagulation is recommended. So the other score that's sometimes used to kind of balance the risks versus benefits of using anticoagulation is the Hasbled score. And this one's honestly used incorrectly many times. So HAS-Blood looks at the 1 year risk of major bleeding in patients who are anticoagulated, and a HAS-Blood score of greater than or equal to 3 means that the patient does have an increased risk of bleeding. So obviously we can see here that, again, there are modifiable and non-modifiable factors regarding HAS-Blood scoring. So as pharmacists, we can play a big role in looking specifically at the drugs and alcohol section to see if any of those are modifiable and can kind of take away some of that bleed risk. But again, if there are no modifiable risk factors, that facilitates a shared decision-making approach as far as understanding the risk of bleeding associated with putting the patient on anticoagulation versus the risk of a future stroke without anticoagulation. So for example, if the CHA2DS2-VASc is 3, but the HAS-Blood is 5, that shouldn't automatically lead us to assume we shouldn't anticoagulate. It should lead to a deeper discussion. So to summarize, if a patient has already had a stroke, then they automatically qualify for the need for anticoagulation since they would automatically have a CHA2DS2-VASc score of 2. And again, in females, because you get a point for being female. So they would automatically qualify. But you would still need to weigh their bleed risk. But chronically, we know that the benefit will usually outweigh the risk, so they will likely need anticoagulation. But the big question that has yet to be fully determined is when to add this anticoagulation. If the patient has not already been on it, or when to resume it if the patient has been on it after they have an event. And so this chart just kind of summarizes the onset and half-life of warfarin and our factor Xa inhibitors, just to give a visual about the two main classes of anticoagulants that we see. And so after we decide that yes, the patient does indeed need anticoagulation, we can start to think about which will offer the most benefit. And just as a hint, many times that will be a DOAC, but we'll get to that. So historically, when a patient needed anticoagulation, they got warfarin because for a long time, that's the main agent that we had available to us. But we know that there are a lot of risks associated with warfarin. And so there's obviously bleeding risks, certain drug interactions, INR variability. And then when our DOACs came to market, we saw that they had a quicker onset, less variability, and as we'll see kind of for the remainder of the presentation, current literature is showing that DOACs can actually be started pretty soon after a stroke, especially depending on stroke severity, without any kind of increased safety risk. And so again, when we think about warfarins versus DOACs, this presentation is not about whether which one is better, but studies have shown numerous times that DOACs seem to be more efficacious for patients who have AFib, unless they have some kind of additional reason to use warfarin, such as like mechanical valve or some kind of genetic clotting disorder that we typically think of. And in fact, the Aristotle trial with apixaban actually showed that apixaban was superior to warfarin in terms of efficacy and safety. And this was the only DOAC randomized controlled trial to show this in this population. So I point this out to say because like the question of when to resume our oral anticoagulation or when to start it after a stroke started to be looked at independently when we were looking to see whether or not DOACs versus warfarin were better from a safety versus efficacy standpoint. And then obviously, why does the choice and timing matter? So again, it kind of goes back to this risk versus benefit of early versus late anticoagulation. So when we think of early anticoagulation, this obviously is likely going to reduce our risk of a stroke recurrence, but it does kind of pose this risk of having an increased risk of bleeding, increased risk of possibly hemorrhage, versus balancing the delayed anticoagulation, which again is going to reduce that risk of bleeding, but possibly increase that risk of stroke recurrence. And so the ultimate goal is to kind of find that balance, that good middle ground where we can optimize patient outcomes, but also make sure that the patients are safe. And so this chart looks at efficacy as far as DOACs versus warfarin. So this is from a meta-analysis of randomized controlled trials that compared DOACs versus warfarin. And it's just to visually show you that standard doses, so that's the lighter blue line, standard doses of DOACs especially were more efficacious, or at least efficacious as warfarin in most instances. And then this visual from the same meta-analysis looks at safety. And so this kind of breaks down the safety outcomes of those DOACs versus warfarin, and again shows that DOACs are generally safer compared to warfarin. And this all kind of starts making the case of that we do typically prefer DOACs over warfarin, unless, again, of course, the patient has certain specific indications where warfarin would be utilized. So studies took this and they started asking the question of, well, okay, we're going to prefer DOACs. So when is the best time to resume this oral anticoagulation? But in order to start answering that when, you kind of have to first define and be able to understand stroke severity in order to look at the literature and kind of how they went through the studies. So the National Institute of Health, or NIH score, or stroke scale, classifies a stroke from minor to severe on a scale from 0 to 42, based on a long list of scoring criteria that we won't go into detail with. But I did want to point out a few things about this scale that could be barriers. So this scale does not factor in the size of the ischemia, like some others. There can also be certain barriers that are patient-specific, because many times this stroke scale, to be utilized, the patient has to answer certain questions. So certain language barriers, factors such as if the patient's intubated, or just having a poor baseline or health literacy in general can factor into this score. The next thing we see is infarct size. And so this is usually determined, again, through imaging, so CT or MRI imaging. And we've actually seen it being used a lot more in recent literature. And then the modified Rankin scale measures the acuity of post-stroke disability, and kind of helps to determine post-stroke abilities. And so this does have some correlation with the volume of infarct. And so again, these scales are more diagnostic in nature. So as pharmacists, we likely will not be the ones defining the severity of a stroke, but it is important that we understand what they mean, how they're classified, because as we get into the literature in just a moment, we'll see that stroke severity is generally correlated with timing of anticoagulation resumption. So this brings us to our second knowledge assessment. So MB is a 76-year-old female who presents with left-sided weakness, facial droop, and slurred speech approximately 2 hours ago. Past medical history includes diabetes, hyperlipidemia, hypertension, AFib, and GERD. After further workup, MB is diagnosed with an ischemic stroke with an NIH score of 7. What is her stroke severity? A, no stroke symptoms, B, minor stroke, C, moderate stroke, D, moderate to severe stroke, or E, severe stroke. So C, moderate stroke. So again, if we base it off of the NIH score, which again is just one scoring system that's used, does not mean it's the best or the worst, just one score that's utilized. It would fall into this moderate range of 5 to 15. So what does literature say? What's coming out? What has come out already? So when we look at the timeline, there's a lot that's kind of leading up to this question, as well as beginning to answer this question specifically of timing and best timing. So the first 3 that kind of laid the foundation were VISTA in 2014 NOACISP or NOASP in 2016, and Samurai in 2020. So what did they show? So VISTA looked to see how many patients received an antithrombotic medication versus did not receive an antithrombotic medication after a stroke. And they did have a section that had combined anticoagulant and antiplatelet therapy, which showed significantly lower risk of recurrent stroke and hemorrhage at the 90-day mark than those not using antithrombotic therapy. So I did want to point out that while this particular study did not look at anticoagulation independently, it did show that the relative risk of recurrent stroke and hemorrhage was highest in the first 2 days post-stroke. So this is kind of the initial framework for asking the questions of how do we balance safety and efficacy for anticoagulation after a stroke. And then we have NOASP, which was a prospective cohort study, which was based off of the novel oral anticoagulants in ischemic stroke patients registry. And they looked at time interval in days between stroke event and start of oral anticoagulation in patients with AFib and ischemic stroke. And so they started to define this early versus late category. So they defined early as less than or equal to 7 days and late as greater than 7 days. And they ultimately found that early start of DOACs, so within a week of the ischemic event, actually poses a low risk of hemorrhage. And I did want to point out that the median delay for this particular study was 5 days. So a median of 5 days to start time of anticoagulation. And starting DOACs earlier does seem to be safe and effective in preventing a recurrent event, despite what some of the initial randomized DOAC randomized control trials had initially presented. So the study actually talked about how in certain trials that brought DOACs to market, so like the Rocket AFib trial that looked at rivaroxaban, rivaroxaban was not allowed to be started for 3 months in patients who had a severe acute ischemic stroke. And then in the RELY trial, dabigatran was not allowed to be started for months due to the increased risk of hemorrhagic transformation with an increase that's correlated with an increased infarcted brain. So in order to get these DOACs to market, they had a very conservative approach as far as time to initiation. But now that we have more long-term safety data available, we've been able to see other studies that start to push those time boundaries and start the anticoagulants earlier, despite certain risks of bleeding. And then we have Samurai in 2020. And so Samurai, again, compared outcomes of DOACs that were started in this earlier versus later time periods after a stroke. And so they looked at certain outcomes such as recurrent stroke or embolism, major bleeding, and death. And they looked at the 3-month and the 2-month mark, or 3-month and 2-year mark, excuse me. And they kind of defined these categories as early being less than or equal to 3 days and late versus being greater than or equal to 4 days after a stroke. And so I did want to point out that in the early group, so this 3-day mark, those patients had a lower NIH score, as well as smaller infarct sizes. And what they found was that there was no significant difference in outcomes at the 3-month mark between the two groups. And so the big takeaway is we probably don't need to hold DOACs for a long period of time after a stroke, because safety and efficacy both kind of point towards being appropriate for early initiation, especially if the stroke was less severe. So Samurai was kind of this turning point in literature where we saw that yes, DOACs are effective, and yes, they're safe. And also, we can start them within 72 hours without any extra risks. And so that brings us to Relaxed in 2022. So Relaxed kind of pushed this time boundary, and it's kind of where we see this 2-day mark or 48-hour mark starting to be considered. So I did want to point out that Relaxed specifically looked at rivaroxaban, and they defined early as within 72 hours versus late would be greater than or equal to 72 hours. And so they looked at outcomes that included a composite of ischemic event, or recurrent ischemic event, or embolism, and then major bleeding at the 3-month mark. And so they did see that the smaller the infarct size, the quicker rivaroxaban was initiated. So again, kind of thinking about if it's a milder stroke, we can start these earlier. And there was also no significant differences in major bleeding or hemorrhage or death. The median time for initiation was 3.2 days for this study. And so again, the big takeaway is that DOACs could be started at the 48-hour mark, especially in minor strokes. Which brings us to timing. So timing is a non-inferiority, open label, blinded endpoint, randomized controlled trial that was published in October of 2022. And it was influential because it was the first randomized controlled trial that we had that was addressing this question of timing of anticoagulation after a stroke. And so I thought it would be interesting to point out a few things about the baseline characteristics in this particular study. So a majority of patients enrolled were already on antihypertensive medications. So a majority had pharmacotherapy on board that could help target one of these main risk factors, kind of, again, going back to Chad's VASC, of stroke. But at the same time, less than half of the patients were on a statin, which could possibly indicate that the majority enrolled had not had a previous event or were not on appropriate pharmacotherapy. And I also wanted to point out that there were some patients who were on DOACs at baseline prior to the study, which is important when we consider the safety results and compare this trial to our newest trial that we'll talk about in just a moment. And so finally, they used the NIH score for severity with a mean of 6.2 in the early group and a mean of 5.9 in the late group and medians of 4 in both groups. So again, if you think back to the NIH score, 1 to 4 is a minor stroke, 5 to 15 is a moderate stroke. So the majority of these patients that they looked at had mild to moderate strokes at baseline. And then this are some results as far as looking at baseline after the trial at the early versus delayed intervention group. And so they defined early as within 4 days after event and late as 5 to 10 days after event. And so I did want to point this out specifically because we can see that the NIH score of 0 to 15, which again is that mild to moderate, is the majority of these patients. And it kind of tends to pull towards the early start group a bit. And then when we get to the greater than 15 is kind of where we start to get into pulling more towards the delayed start. So again, we know that stroke severity is a big component when we think about timing. And so again, just to wrap up for timing, the timing trial, early initiation was non-inferior to late initiation. And so there were no cases of hemorrhage in either group, which again is important to note, especially because they did have some patients who were on full doses of anticoagulants at baseline, though it was a small number of patients. And then rates of recurrent stroke and death were lower in the early group. So the big takeaways from the timing trial showed us that the same results from previous non-randomized controlled trials that did favor early initiation of DOACs, keeping in mind that this was for a mild to moderate patient population. And so then we get to ELAN. So ELAN is an international multi-center randomized controlled trial that was published in June of 2023 that assessed early versus later anticoagulation for stroke with atrial fibrillation. And so they defined early as within 48 hours in mild to moderate stroke or 6 to 7 in major stroke. And then they defined late as days 3 to 4 in minor stroke, 6 to 7 in moderate stroke, and 12 to 14 in major stroke. And you can see kind of at the bottom how they defined this minor, moderate, and major criteria. And so what was new about ELAN is that they determined stroke severity based on MRI and CT imaging. And they also, it's important to note that they excluded patients who were on therapeutic doses of anticoagulants, which is something that the timing trial, again, we know, did not exclude. And so this is just a visual of some outcomes from the trial. So they looked at a composite outcome consisting of recurrent ischemic stroke, symptomatic hemorrhage, major extracranial bleeding, systemic embolism, or vascular death. And at the 30-day mark, the composite favored more prompt treatment. So the 2.9% versus 4.1%. So again, seeing that early treatment group that's favored. And so just kind of to wrap up ELAN, so this trial showed that early initiation did have some similar composite outcomes with the late initiation. So the big takeaway from ELAN is that DOACs are safely utilized at the 48-hour mark, and it also brings to question if imaging should be routinely utilized to assess stroke severity. And so then we have a few trials that are in the pipeline currently. So first we have the START trial. So what we know about the START trial is that they are also using an image-based approach like ELAN to determine stroke severity. And they are stratifying timing of anticoagulation based off of stroke severity. So they are looking at moderate stroke will have an anticoagulation resumed at 3, 6, 10, or 14 days after a stroke. And then severe stroke will have anticoagulation resumed at 6, 10, 14, or 21 days after a stroke. So this is unique because up until this point, we've really only had patient populations that kind of fit into this mild to moderate population. And so the START trial will be looking at this kind of moderate to severe patient population. So hopefully this will give us better insight on the safety and efficacy and how that correlates to anticoagulation timing in these patients. And so the primary outcome is looking at a composite of recurrent ischemic events or hemorrhagic event at 30 days. And so this is actually expected to be complete this month. I already checked before this and it is not done yet, but hopefully we will have some results in the near future. And then we get to Optimus. So Optimus is the final one that's in the pipeline currently. And what we know about Optimus is that early versus delayed initiation will be similar to the timing trial, in that early will be within 4 days and late will be within 7 to 14 days. And so the primary outcome, again, is a composite of recurrent ischemic stroke or symptomatic hemorrhage and systemic arterial embolism within 90 days. So one question we don't know yet is how they will classify or determine stroke severity, but this study is expected to be complete next spring. So within the next year or two, we should have a lot more answers regarding timing. So what do guidelines say? As far as guidelines are concerned, the AHA mentions that it's reasonable to initiate oral anticoagulation between 4 to 14 days after the onset of neurological symptoms. And then European guidelines make no mention specifically of DOACs, but do recommend against using IV anticoagulants or warfarin to be initiated less than 48 hours after a stroke. So again, this leaves room for interpretation and clinical decision-making, especially when we think about our DOACs. And again, studies are showing promises with that early start time. So this is the 1-3-6-12 rule. And this approach is a little bit more conservative regarding timing of DOACs after a stroke. And so basically this looks at again, stroke severity, and then how many days. So you would either start it at 1, 3, 6, or 12 days if imaging is stable. And then this is the 1, 2, 3, 4 rule. And this was put out by an AHA article in 2022 that came out as a result of the 1, 3, 6, 12 rule. And so this 1, 2, 3, 4 rule looks more similar to what recent literature has been showing as far as resuming DOACs based off of severity and kind of factoring in that 48-hour mark for mild strokes especially. But I point both of these out to say that there's multiple approaches to practice, and this kind of spotlights the variability that's everywhere regarding the question of what's the best time to start a DOAC specifically after a stroke. So what does it all mean? Because that's a lot of literature and a lot of information. So obviously, this is going to require a multidisciplinary approach and conversation. And so you should always be considering the risk versus benefits to the patient, looking at imaging and stroke severity. And then pharmacists can actually play a big role in relating this current evidence to assist in therapy decision-making. So again, as pharmacists, we're likely not going to be the ones determining the severity, at least not independently, but we can make sure that proper follow-up occurs once the stroke severity has been determined. And we can make sure that the dose is appropriate based on acute factors that may be impacting the patient. So like if the patient, if the dose needs to be renally dose adjusted in a patient with an AKI. And then this chart is just for your reference as far as appropriate dosing of commonly used DOACs in AFib and their respective doses and dose adjustments. So this brings us to our final knowledge assessment. So MB's repeat CT at 24 hours was stable. You were on rounds and the attending is asking you for a recommendation on when to resume her home anticoagulation. Based on her moderate severity, when should you restart her apixaban? Is it A, this is only up to the neurologist, B, now, since it's been 24 hours and she's stable, C, at the 48 to 72 hour mark, based on analysis of her bleed risk in collaboration with the rest of her team, D, do not restart inpatient, she should follow up with her PCP outpatient, or E, I need more information. C, exactly. Again, emphasizing that this really is a collaborative approach that the healthcare team should have. So what do future projections look like? So we know for a fact that more literature is in the process of coming out. And I would imagine personally that more will continue to develop as more questions are raised regarding specific agents or severities or even certain patient populations. And it's even possible that we could see like a head-to-head comparison of DOACs kind of to determine safety and efficacy and if there's non-inferiority between certain DOACs, as well as correlating that to appropriate timing. But we do need better consensus on severity and how to determine it. So I don't think there's a one-size-fits-all approach to this as far as analyzing the severity of a stroke, but I do think, I do anticipate that based off of the trials that we've seen so far and what we know is coming up, imaging is going to be used a lot more to start determining the severity compared to just symptom scoring, which could possibly help eliminate some confounding variables there. So in summary, timing of oral anticoagulation still is very patient specific, especially for our kind of moderate to severe strokes, and it warrants a lot of shared decision making. And there's still a lot of unknowns regarding, again, this moderate to severe group, but I'm hopeful that the START trial will start to give us some more answers regarding this severity population. Um, and finally, one thing that I've discovered in my experience as a learner so far is that practice is very provider specific and institution specific. However, literature, I think, as we can agree, is showing really promising results as far as starting DOACs. And they're safe and effective to be started at the 48-hour mark, especially in patients who have had this mild and usually mild to moderate strokes. So I do think that resuming or initiating a DOAC 48 hours after a stroke is both safe and effective in this severity group and should be considered a standard of practice. What questions do you have?
Question. I'm just curious as to whether in these trials the authors discuss their thoughts about so for patients who have received multiple-place or TEA, does that impact your decision even in the mild to moderate group about starting at the 48-hour mark?
So both timing and ELAN specifically both used, had a section of their patient population who did receive thrombotic therapy or a thrombectomy. Both of those, I believe, were more of a severe, obviously with the need to use that kind of therapy, more of a severe stroke. So it would be, when we think about starting at the 48-hour mark, that's more going to be that moderate to severe population. So the question was if the patient required starting warfarin, when would be the best time to start that? And I think that's, again, very patient specific, because you would have to consider factors of how long had the patient been off of warfarin? Do they need to be bridged? What does their current risk of bleeding look like? If they're inpatient, we know that their diet might not be the same as it is outpatient. So I think weighing all of those would have to factor into that decision as well. There is how to get your CE credit.